The word Candida usually evokes a routine medical nuisance, but a specific strain has weaponized that familiar label to mask a highly lethal drug-resistant threat. It is 3 a.m. in the ICU. Nurse Priya is managing an elderly patient on a ventilator. He has a central line and a persistent low-grade fever that antibiotics have failed to clear. The blood culture returns with a vague result. Candida species, further identification pending. For a seasoned ICU nurse, Candida usually means oral thrush or perhaps a minor urinary tract infection. It rarely demands immediate alarm. 2 days later, infection control identifies the exact culture. It is Candida auris. The patient in the adjoining bed, someone Priya also cared for on that exact shift, has just tested positive as well. This quiet, entirely undramatic spread is exactly how ICU outbreaks begin around the world. Treating a yeast infection as a mere nuisance is a standard professional assumption. It is exactly the blind spot this organism exploits to achieve unit-wide transmission. Candida auris is a yeast, a type of fungus, entirely distinct from bacteria or viruses. It was first identified in a patient's ear canal in Japan in 2009. While it belongs to the same family as the fungus that causes common thrush, its biological behavior is severely aggressive. Health authorities placed it on their urgent threat list. It is the first fungus ever to sit alongside the most dangerous drug-resistant bacteria. Since its discovery, clinical cases have climbed rapidly every year in the US. Recent data shows the curve slightly slowing, an early result of aggressive new isolation protocols. This pathogen exposes a global structural failure in how healthcare systems traditionally identify and treat fungal infections. The familiar Candida albicans is mild and easily treated. Candida auris is armored, resistant, and highly dangerous. It defeats standard hospital defenses using 4 specific advantages. First, severe drug resistance to multiple major antifungal medications. Second, environmental survival, living on skin and dry room surfaces for weeks. Third, laboratory evasion, as standard hospital tests frequently misidentify it as a harmless yeast. This misidentification causes dangerous delays in recognizing the true threat and initiating vital isolation precautions. Fourth, silent spread. A patient can be colonized, meaning they carry the yeast on their skin with 0 symptoms without actually being sick. These colonized patients act as invisible reservoirs, passing the fungus across the ward without ever spiking a fever. Candida auris bypasses our diagnostic, pharmacological, and environmental safety nets before it ever has to challenge a patient's immune system. The highest risk falls on patients with long ICU stays, weakened immune systems, or invasive devices like central lines and ventilators. Patients on heavy, broad-spectrum antibiotics are in extreme danger. Eradicating the body's normal flora gives fungi an obstructed room to multiply. Once introduced, the single most common route of physical transmission across a ward is a healthcare worker skipping hand hygiene between patients. Secondary vectors include shared equipment. Blood pressure cuffs, thermometers, and glucometers physically ferry the pathogen from room to room if they are not cleaned. It anchors itself to curtains, call bells, and bed rails by secreting a sticky protective layer called a biofilm. This biofilm acts as a microscopic shield, rendering many everyday generic hospital surface wipes completely ineffective. Consider a documented outbreak from a US state health department. A single locally acquired case quietly moved between patients. It eventually triggered a massive regional transmission event, sweeping across multiple facilities over 2 years. Containing an outbreak forces an extreme operational toll, requiring intensive biweekly swabbing of every patient on a unit until 2 consecutive rounds return clear. The common thread in all invest is that the second and third cases never arrive via dramatic clinical events. They happen through ordinary, everyday contact. An unchanged glove or an unsanitized glucometer is the primary engine of a multi-year regional outbreak. Recognizing this threat at the bedside is difficult because there is no unique defining symptom. You must raise the flag when a high-risk, device-dependent patient has a fever or bloodstream infection that will not respond to standard antibiotics. Understanding the doctor's antifungal choice is critical for the bedside nurse monitoring the patient's clinical response. This graph illustrates the failure of azoles, like fluconazole. Doctors often try these familiar drugs first for routine yeast, but most Candida auris strains actively resist them. A patient failing to improve on fluconazole is a massive red flag. It is not a reason to wait and see. Echinocandins are the required first-line intravenous treatment. You will be responsible for administering these infusions and monitoring the patient's vitals for improvement. Because of biofilms, ordinary room cleaning is not enough to stop transmission. You must use specific disinfectants proven against Candida auris. Generic surface wipes are forbidden. Terminal cleaning of a room after discharge is an absolute non-negotiable requirement to break the chain of transmission. UV light disinfection is a highly useful add-on to combat biofilms, but it can never replace rigorous manual scrubbing. Surviving this pathogen requires escalating both pharmacology and environmental hygiene the exact moment it is suspected. Mr. Verma, a 68-year-old patient, has been in the ICU for 3 weeks on a ventilator. Today, he spikes a new fever. His blood cultures are pending. But you just discovered his discharged roommate from last week was confirmed positive for Candida auris. Before the lab result comes back, what is your immediate bedside reaction right now? First, initiate full contact precautions immediately. Put on a gown and gloves based on suspicion alone. Do not wait days for lab confirmation. Second, immediately notify both the attending physician and the infection control team. Explicitly flag the roommate connection. Third, dedicate all vital equipment, his blood pressure cuff, thermometer, and glucometer, strictly to his room to prevent physical transfer down the hall. Finally, ensure this suspected status is communicated loudly and clearly at shift handover and to any transport staff. In the critical window between a spiked fever and a confirmed lab result, a frontline nurse's empirical action is the only fail-safe against a systemic outbreak. Candida auris does not spread through dramatic biological events. It hides silently behind our daily fatigue and routine assumptions. The only difference between a single isolated case and a devastating 2-year state health investigation comes down to mastering the absolute basics of bedside care. You are the ultimate line of defense holding the unit together. Every gown, every glove, every swab,